Hello everybody, and thank you for coming here. We tried a lot to find a name for this session. That's why we have put the name Diabetes Education Efficacy in different structures and countries. So we have different levels to make the diabetes education, and in my presentation I'll try to give an overview of diabetes education in general and some examples that we have done in Albania during this period of time. But first, let me present you
They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Thank you, everybody. So, this is a little bit the story with every chronic disease, and diabetes, it's not an exemption from that. Because when we have the diagnosis of diabetes, we have a loss of patient's health state. And from that, we have to work with the patients, together with the patient and the whole healthcare providers, to make the patient accept the serious nature of their condition, and from there to create a relationship between us, healthcare providers, patient and family patients, to make progress in the diabetes management. And diabetes education, it's really a very important part of it. Because at the diagnosis of type 2 diabetes, nearly 50% of the patients have already one complication. And 2/3 of our patients, they do not achieve the target glycated hemoglobin. Diabetes cause is increasing every year. And this is true for the whole world. Here we have some results only for the United States, that for the year 2020 it was provided that the total expenses due to diabetes will be more than $192 billion. But the figure now it's even higher than that was prevalent for the year 2020. And also glycated hemoglobin targets are converging. Good glycemic control is not reached because, as we said before, 2/3 of individuals with diabetes do not achieve target glycated hemoglobin. And the situation is even worse than it was before. If we see in these slides, we see that in 94, about 44% of the patients has a glycated hemoglobin of less than 7%, and in 2000, 37% of the patient has a glycated hemoglobin of less than 7%. So it's even worse results than before. And to make an improvement on diabetes control, we need to increase the adherence of patients. In a study made in United States, only 62% of the patients took correctly the oral antidiabetics, and 20% of them regularly forgot to take their tablets. When we come to the patient's knowledge about their treatment, about 35% of them recall to receive some advice about how to take these prescriptions, and only 15% of them knew the mechanism of action of their therapy. And there are a lot of questions that the patients, they do not dare to pose to their healthcare providers, and the biggest fear of them is the insulin therapy. I have put a quote from the General MacArthur, who said that the history of failure in war can almost be summed up in 2 words: too late. And we can say the same thing from a chronic diseases treatment. And diabetes education is just what we want to do just to prevent this. Because if doctors, nurses, dietitians would have given more attention to their patients at the time of diagnosis of diabetes, those patients would fly better, adhere better to their daily treatment. And this is the aim of therapeutic patient education. It is to help the patients deal daily as well as possible with this chronic disease, to improve and to maintain their quality of life, their autonomy and their adherence to treatment, and to avoid or decrease relapses and especially complication of diabetes. So the objectives of therapeutic patients education are to get knowledge and to gain competencies on diseases and treatment, to understand and to accept the disease, to manage the disease and to find the autonomy, to change the behavior and to help the patients to change and to grow in life. The three tasks of the healthcare providers are to understand the disease, to understand the patient, and to understand the person, because it's not just the disease that we have in front of us. We have a person with a background, with a family around him. That's why it's important to have a multidisciplinary team, which are the main part are physician, dietitian, diabetes specialist, nurse, and podiatrist. But there are other members that are important in the multidisciplinary team: diabetologists or endocrinologists, other specialists, pharmacists, and what is more important, it's patient's family. There is a quote that says that sailor doesn't pray for the wind to blow, he learns how to sail. And we try to do the same with our patients. Diabetes education has a long story of successes. It begins with Leona Miller in 1972, who shows that through diabetes education we decrease the number of comas per year, we decrease the number of food problems, and we decrease the phone calls to the doctors. Professor Assad, in 1993, he shows with a study that through diabetes education we can decrease the number of lower extremity amputation of the toe, below knee, and above knee. Different studies have shown that through diabetes education we can reduce the cost by up to 62% in a year. We can decrease the glycated hemoglobin, and we can improve all the other cardiovascular risk factors in people with diabetes. We can reduce the number of hospitalization of about 50%, and we can decrease for more than 1% the glycated hemoglobin. And now it is part of our experience for the diabetes education. We have since the 1980s a program of education which has been improved time after time, and we have a multidisciplinary team working on diabetes education. This is a program for the 1 week from Monday to Friday in our service of endocrinology. And on 2011 we made a study taking in examination the patient participating in this education program. We measured the glycated hemoglobin at baseline, at 6 months and 12 months after the education, and also a questionnaire of quality of life at the beginning and 6 months and 12 months after the education. About 400 patients participated in this study. About 35% of them were men and 65% were women. The average age was 44 years old, diabetes duration 11 years, and from them about 45% were in insulin treatment. The glycated hemoglobin at the beginning was 9.1%. It decreased in 8.5 in 6 months and in 8.02 on 1 year. And for the quality of life, we have an improvement of quality of life for this patient in 6 months and 12 months after the education. And the satisfaction with treatment and worry about the future were the most improved scores at 6 and 12 months later. As for the pedagogical skills evaluation, we have trained our nurses, young doctors, and dietitians how to communicate with the patients during these education sessions, how to involve them in the education, how to pose open questions to increase the participation, the active participation of the patients during the education. And due to this education of the educators, the course duration increased by 25%. The patient speaking time passed from 5 minutes to more than 7 minutes. It seems like nothing more than 2 minutes, but it is about 70% more time of patient speaking during the course than it was before. Because in general, our courses last from 20 to 30 minutes. And as far as it concerns the number of open questions during the education sessions, it doubled after the training. On 2016, we made a questionnaire to the level of glycated hemoglobin for our patients from the association through the phone calls. In 2 months, more than 900 phone interviews were conducted, and from there we have 650 patients that answered to the question. The response rate was 72%. Only 30% of the interviewers have realized glycated hemoglobin in the last 6 months, and the mean glycated hemoglobin was 8.65. 25% of the patients have more than 1 year without performing the glycated hemoglobin test. But 3 months after the survey, we phoned again to these patients, and surprise, 50% of them have performed the glycated hemoglobin after our phone call. So with just a phone call, we can make a lot of things. Diabetes education and treatment is like a bridge with different parts, which every one of them is very important. And education is a very important part of diabetes treatment. But we need to educate the patients, but we need to educate the healthcare providers also. That's why, since the November of 2013, we have begun different training sessions for healthcare providers. For example, we have done more than 60 training sessions with GPs in 16 cities in Albania, with more than 1,500 general practitioners participating in our training sessions. And we have completed a questionnaire about their level of knowledge about diabetes. The number of correct answers for these GPs before the training session was only 51%, and only 15% of participants answered correctly to more than 80% of the questions in this training session. They have an improvement of about 20% in their level of knowledge after the training sessions, but we haven't followed up if this knowledge is continuing to improve after this training session, or if they are more interested about diabetes after these training sessions. We have done another simple education program involving patients and motivating them to do more physical activity, putting them on pedometer during the 24 hours and asking them to do at least 10,000 steps per day. But before that, we just measured the effect of a simple physical activity session at the level of glycemia, and we have seen that in 6 hours after the physical activity, the level of glycemia decreased of about 70 milligrams, or around 4 millimoles. So it was just to give these patients some examples that why it's important to make more physical activity. And what is more important is that at the beginning of the program, the average number of steps for each patient is less than 5,000 steps per day. At the end of the program, of 3 months program, the average number of steps was more than 11,000 steps. And this has given an improvement on glycated hemoglobin from 8.4 to 8.2 in just 3 months period. A small decrease in weight and a decrease of body fat measured with the special equipment. So, as conclusion, therapeutic patient education has a major effect on quality of care, control of the disease and quality of life, and we can add that we can do it everywhere that we can, and in every method that we can. Patient-centered approach to help him deal daily with his chronic disease, approach which enables a better quality of life and efficient for medical costs. And we have to remember that $1 spent for therapeutic patient education can save $3 to $4. But patient education and self-management is not just a nice accessory. As Konrad Lorenz said but not heard, heard but not understood, understood but not accepted, accepted but not put into practice, put into practice but for how long? It is the same for diabetes education, but even for the educators. And to begin, what is more important is to listen. To listen is to give a hand. And listening is part of diabetes education too. Thank you for your patience.